Welcome and thank you for attending the Molecular Pathology webinar, Outcome for the 2013 Medicare Gapfilling Process. My name is Stephanie Hoyle and I'm the Marketing Programs Manager for Diagnostics. Today's webinar summarizes the outcome of the recently concluded Medicare Gapfilling process for 114 new molecular pathology codes that were implemented in 2013. We will address the final 2013 regional rates for these codes and the implications for national payment rates in 2014, and also take a look at upcoming changes in the molecular diagnostic reimbursement landscape. Today's webinar, along with the slides, will be available on our website within 48 hours at www.illumina.com/reimbursement under the webinar tab. You can also find downloads for the entire reimbursement webinar series on this website as well. Our presenter for today's webinar is Mr. Kuo Tong, CEO of Quorum Consulting, a healthcare consulting firm based in San Francisco, California. Mr. Tong's background is in health economics and policy, and he is a recognized leader in the reimbursement for advanced diagnostic tests. Kuo?
Good morning, everyone. Thank you for that introduction, Stephanie. In the past webinars, we really tried to help laboratories understand how they could play a role in the gap filling process. And now that CMS has issued its initial rates for calendar year 2014, we want to take the time now to look at what CMS has done and understand what some of the implications might be for clinical laboratories. So by the end of today's presentation, I hope everyone will gain a good understanding of how these changes might affect your lab and be familiar with what the outcomes are, what the implications might be, and also some of the future developments that are still to come in this rapidly changing molecular diagnostic space. Finally, at the end of the presentation, I'll summarize some of the key takeaways and we'll open up the webinar to Q&A, which any of the attendees can type into the webinar interface. We'll answer any questions that the attendees may have. With that, let's go ahead and review what the MoPath rate setting process looked like over the past couple of years. As many of you know by now, in 2012, the American Medical Association developed a new set of analyte-specific molecular pathology, or MoPath codes. And these codes were intended to replace the old methodology-based stacking codes for services such as PCR and microarrays. And effective in January 2013, CMS and many other payers asked laboratories to start using these new codes and delete from their billing systems the old stacking codes. So that was the timeline and the transition in terms of the implementation of the new codes. But with the new codes, there were no national Medicare rates that were established, and that's what put us down what is the gap filling process. So while the codes were released in January of 2012, in the fall of that year, CMS said that the Tier 1, Tier 2 codes would be gap filled in 2013, meaning that the local Medicare administrative contractors would be responsible for setting their own rates in the interim. And that information would subsequently be sent to CMS so that national limitation amounts for these codes could be aggregated and issued to be effective in January 2014. This graphic just summarizes all of these milestones along the timeline of what we've been dealing with here in 2013. And as you can see, here in October, many of these milestones have already been met. Most notably, that CMS has attempted to issue a national amount for as many codes as they could to be effective January of this coming year. It's really important to note, though, that while CMS has indicated these are the national amounts for 2014, we are still in the process of an open public comment period where we have 30 days to comment on these rates and provide additional information to CMS, especially in the event that we believe that the rates are inappropriate. And those comments are due to CMS by October 30. So we are in a time period here where we have about a week's worth of time to still submit additional comments to CMS for their consideration. So what did CMS come up with through this process in 2013? So as many of you know, the rates were issued, although not for every code. There were a number of codes where the Medicare contractors did not have enough information or did not pay any claims, and therefore there are a number of codes for which no national Medicare amount has been released. And we'll go through some examples of codes where national amounts were priced and in situations where national amounts were not released. And if you are interested in looking at all of the codes and the national amounts, the URL at the bottom of this page, you can access that to get to the CMS website. So here's an example of some codes that and the finalized rates for 2014. And you can see here that for cystic fibrosis testing, CMS did not issue a national amount. And it's possible that CMS's contractors didn't actually receive any claims or pay any claims during this period of time. And so while individual contractors may have issued some interim fee schedule amounts, at the end of the day, as that information was aggregated up to CMS, the agency decided that it should not issue a national amount for those particular codes. On the right-hand side of this slide, you can see for many of the somatic cancer mutations, here's a list of codes and then national amounts for these codes. And again, not every code was necessarily priced. And we'll go through this again in some more detail, but the key takeaway here is that you should look at your test menu, look at what CMS was able to price. And again, not always assume that CMS was able to price every code. So we're in the process of this 30-day comment period, and the information that CMS is requesting is that if you offer a certain test and believe that the pricing should be adjusted, that they would like information about the test, how the test is performed, as well as specific costs to perform the test, including both direct and indirect costs. And I think that's really important because many of us in our labs deal with not only variable direct costs in terms of reagents and labor, but we often have significant indirect costs as well. And CMS has indicated that they would like that information if they were going to reconsider the pricing for any of these codes. And a lot of people have questions about what does the NLA or National Limitation Amount really represent. And what the NLA is the upper limit on payment. And MAC contractors have the ability to make some adjustments on the downward side, but the NLA would be the highest that a contractor would pay for any given code. So with these numbers, I think everyone wants to compare and benchmark where some of these rates came out compared to some historical numbers. And here we took 3 common mutations, BRAF, EGFR, and KRAS, and we wanted to show you how the fee schedule amounts changed from the proposed rates earlier this year to what was issued as part of the final rule by CMS. And you can see here that there's both upward and downward adjustments. And the most important thing is not to say was the adjustment appropriate or inappropriate, but I'd like to point out that CMS is open in this process to taking your comments and making adjustments as needed. And even with the final NOA amounts, we still are in this reconsideration comment process, and it's up to the labs to actually submit information and request changes. Otherwise, these rates will go into effect. So it is incumbent upon us in situations where we believe the fee schedule amounts are not appropriate, to please provide those comments to CMS. So what are the implications of these new rates? First and foremost, something that I mentioned before, it is important to acknowledge that not every code was priced by CMS on the fee schedule. And it's important for the individual labs to understand which codes were priced and which codes were not, because this will have implications not only for working with your local Medicare contractor, but for other payers for whom you perform services. Certainly, when there's a lack of a national CMS fee schedule amount, it may be worrisome that other payers, commercial payers, managed care plans, state Medicaid agencies, do not necessarily have a national benchmark for them to set rates. And therefore, labs will need to certainly work with these other payers and educate them about the tests, the cost of doing the tests, and how these other payers may go about pricing these codes in the future. So now that we've reviewed the status of the rate setting process, I did want to take a look at some very specific test offerings and talk about what is the reimbursement landscape, both in terms of coverage and coding and payment for these specific areas. So we'll cover cystic fibrosis testing, we'll cover molecular cytogenomics, and cancer testing, just to give you some more detailed information on what is currently going on in the payer marketplace. So with CF testing, I don't think it's surprising that we are faced with a generally very positive private commercial payer coverage landscape, and that these tests are widely covered by most private insurers and managed care plans. And while many state Medicaid agencies do not have a specific or explicit coverage policy, we know that many Medicaid states also cover this type of testing for their patients. For those of you in the space, I'm sure you're very familiar with the family of codes that were created, 81220 through 81224, for different types of CF testing. In this table, we summarized the original proposed fee schedule amounts. And as I mentioned before, at the end of the day, CMS decided not to issue a final NLA amount, but certainly the proposed amounts are available for reference. And again, because CMS did not take action, and Medicare really isn't obviously the primary payer for these patients, it'll really be up to the labs to work with their individual payers to try and set the fee schedule amount for these codes going forward. In this next set of slides, we'll review the state of play for molecular cytogenomic testing. And again, the coverage landscape here has been evolving, but gradually has gotten more positive over time, where we're seeing more and more private commercial payers and managed care plans covering CMA. And similar to what I showed you with cystic fibrosis, many Medicaid plans do not have any formal written policies in place, but we know in many cases they are paying for the testing as well. The codes in this area are the 81228 and the 81229 codes, and you can see the difference between 28, which is the back array, versus 29, which includes copy number and SNP variants. And in this case, we know the initial NLA rates were very low, and again, because many of the contractors did not process any claims for these codes, there was no national fee schedule amount that was issued. And as I said before, in these cases, it is very important for the labs to continue to work with their payers to understand the complexity of the testing, the amount of work and labor required to perform these tests and issue reports so that appropriate fee schedules can be established. Many of you are in the oncology space, and we'll go through a similar assessment of the coverage and the payment landscape for oncology testing. And here I just picked two examples of BRAF and EGFR testing and summarized how many payers have issued policies for these mutations. And again, generally very positive. And in many cases, payers are silent. They have not had the time or don't have the technical capabilities to do a full policy or assessment. And in their main cases, there's simply no policy. And that generally means the codes can be submitted for processing. Once again, on the Medicaid side, we see a lot of states without formal coverage policies. Again, but not any different than what we saw with CF and CMA. On this slide, we summarize some of the common mutations in oncology and the codes, as well as the CMS fee schedule amounts. And you can see there's some variation here of certain codes paying less than $100 all the way up to several $100s in different cases. And again, if you believe that these the codes for which a national amount was issued is inappropriate, we would highly recommend that you take advantage of the comment period and submit your comments to CMS. I always like to clarify that when there are policies in place that govern the use of any individual code, that laboratories and physicians are aware of any additional requirements that the payers may have in place in order to get reimbursement for the code. And in oncology testing, there may often be requirements that patients may be of high risk or may need to be evaluated for treatment decisions. And that's information that should be charted and maintained in the medical record in order to support reimbursement. In this table, we've summarized for some common genes and the codes some examples of the types of coverage criteria, or in some cases exclusion criteria, that the payers may have put in place and written into their policies as part of coverage for these individual analytes. And while this is by no means comprehensive, my advice to the labs is usually to make sure you're familiar with whatever policies your payers may have in place and understand what some of those requirements or restrictions might be, so that in submitting claims for different tests that you've properly documented the medical necessity when seeking reimbursement for any individual test. This slide just goes on and shows some additional data from payers in the same light as I talked about before. And you'll see in some cases, again, payers may not have a policy in place. And knowing that is just as important as knowing whether there are any specific inclusion or exclusion criteria. So obviously, this process is not done. There are other developments on the horizon, and I want to make sure we cover some of the additional developments on the reimbursement front. And many of you that are either have adopted or considering migrating to next-gen platforms, you may be aware that starting earlier this year, the AMA CPT, working closely with AMP, are in the process of developing yet another code set to address next-gen sequencing. There's been subcommittees set up to start developing these codes. They anticipate certain code proposals to be submitted later this year, discussed in 2014, with the possibility that new codes for next-gen will be available starting in January 2015. And similar to what we saw with the Tier 1, Tier 2 codes, this timeline of January 2015 would be for the release of the codes where they could be used by labs and by payers. And I simply want to caution that the rate setting process for codes is on a separate timeline from this timeline, which is actually writing and issuing the code. So as of now, the earliest date when next-gen codes may become available is January 2015, and then the rate setting process will be separate from that. So what are some of the key elements to what these groups are talking about when we talk about writing codes for next-gen sequencing? They have tried to develop some sort of hierarchy that looks at test complexity and resources and work required, from multiple gene sequencing panels to whole exome, whole genome sequencing. So there is a hierarchy that they are thinking of putting in place. They are very focused on trying to have the clinical question or patient condition spelled out as explicitly as possible in the code descriptor so that we understand the rationale behind the testing, not simply listing specific analytes. And the last part that is very much part of the initial proposals is that the codes will come as partners or families, where there will be a code for the technical performance of the test or the test panel, and then there will be a report and interpretation component that is typically reserved for physicians in terms of billing for the pro fee or professional component of these tests. So these are some of the concepts that are being discussed in writing rules around how to create next-gen codes. None of this has been finalized, of course, but these are some of the proposals being tossed around. As I mentioned before, there are specific work groups being set up by the AMA to start drafting code proposals, and this slide shows you the 8 different work groups that have been developed to write codes for these specific tests. And as I mentioned before, the initial timeline would be for some, if not all, of these proposals to be surfaced later this year, to be potentially voted on in early 2014 for possible implementation January 2015. Another important development on the coding side of things, independent of what the next-gen work groups are working on, is that the AMA and McKesson have announced a partnership where McKesson would act as a intermediary and provide labs and payers and other healthcare stakeholders with a way of identifying new tests that are being developed, and in some sense is a little faster, a little bit more real time in getting codes identified for new tests. And that product from AMA is called CodeBridge and is based on the McKesson Z code identifiers that were launched as part of the Palmetto MolDX program, for those of you who are familiar with that process. And as many of you know, the number of tests that are available certainly exceed the 100 or so AMA CPT codes that are available. So the problem statement really is, how do labs identify these tests? How do payers identify these tests that go beyond just the Tier 1, Tier 2 codes? And this partnership is a way for the AMA and the labs and the payers to submit information to the code bridge process so that more information about what the test does, what evidence is available surrounding the test, how the test is performed, all of that information would be housed to allow payers and labs to reach agreement about coverage and payment for these new tests. So this is something that is going to be launched in early next year, but will be another conduit that labs can identify their tests for reimbursement to payers. This slide walks through how the process would actually work, and it is currently set up to be voluntary so that the labs would decide to participate and submit their information to McKesson via the Diagnostics Exchange, and that's where a Z-code identifier for a test would be issued. And then the submitter, again in this case the lab, would then decide whether to share this information as part of the AMA CPT process, whether they want to submit this information to payers. McKesson has made it very clear that it is an opt-in program for the labs, so that the labs control the level of information that is shared with outside parties. So some of the implications of the AMA-McKesson partnership in terms of what this system is trying to resolve. Number one, I think from the payer side, the payers would like more transparency about what is being performed and the evidence behind it so that they can make reimbursement decisions. So those who decide to participate, you're certainly being more transparent with payers in terms of what's being performed and the literature and evidence surrounding the clinical utility of the test. With that, naturally, comes increased scrutiny. And again, labs need to be aware that the information they submit, in essence, will be viewed through the lens of clinical utility and coverage. So it's simply participating is not a neutral event. If you opt in and allow for the release of that information, it will be evaluated and scrutinized. And lastly, the system is set up to continue to allow for payment variations. Just like we saw with CMS, CMS issued national fee schedules in certain cases and did not issue national fee schedules, so different payers are still left up to their own devices to try and pay for different tests. And this system will certainly continue that, in that while a Z-code may be made available for your test, the pricing of that is not done within this system, that the pricing would still be determined by you and the payers who are deciding to reimburse for those tests. At this point, I will pause, and we'd be more than happy to take any questions from the audience.
Thank you so much, Quo. And just as a reminder, all of this information, the webinar and the slides, will be available within 48 hours at the website that's listed on the screen, www.illumina.com/reimbursement. And you can also find there all of the previous webinar series slides and webinars as well. So we do have a question, Quo. And it's, since CMS did not set rates for the Tier 1 and Tier 2 codes for 2013, there's been some widespread inconsistency on reimbursements for these codes in 2013. If CMS does not set rates for certain codes, in particular CF 81220 in their 2014 lab fee schedule, what do you believe the impact will be in regards to reimbursements and reimbursement rates?
Yeah, it remains to be seen what the impact will be of CMS not setting a national rate. In some cases, we know that managed care plans and commercial payers try to lean on CMS MAC regional numbers in some cases. And we also are aware that commercial payers and managed care plans, through their networks of labs and relationships with labs, decided to set rates independently. So I think the question is dead on in that throughout 2013, we saw variation not only within the MAC contractors, but we saw variation across different payers. And the effect of CMS not issuing a national rate is basically more of the same through the remainder of 2013 and into 2014, where labs and payers, again, are left to their own, in essence, to try and determine what those rates might be. I think over time, we would expect more consolidation, and we would expect more commercial payer rates to gravitate toward certain numbers, either due to their network relationships or volume of services from specific labs. But unfortunately, it is going to be quite variable. And in some sense, the labs are still empowered to try and work with their payers to set the rate. That is the net effect, is basically more of the same. Now, that could be a good thing or that could be a bad thing. In some cases, it's obviously a lot of work working with individual payers, trying to get them to what might be a better number. But that is the opportunity that is in front of us, especially given that that CMS did not issue a national rate.
Thank you for that. There's another question on, is there any chatter regarding tests for the microbiome?
There is, and at this point, there's nothing that I can share from a public standpoint. I think we are certainly dealing with areas where technology and our ability to offer certain tests is outpacing the ability of people who write codes to understand and define all of those tests. So I think there is chatter about it, but you can see where the initial types of proposals are. I would not expect anything immediate in the short term because these things do take some time.
Okay, thank you. How are labs handling MAAs with these new codes versus stacking?
Right. So while I did not cover it in this presentation, the multiple analyte algorithm tests, analyses, MAAs, those codes were not priced for 2014. CMS had a very interesting statement, which was they did not believe the algorithmic component of MAAs could be priced on the clinical laboratory fee schedule. So for now, those MAAs with a Category 1 CPT code will continue to be priced by local contractors. So of the handful of MAAs, they appear much like the Tier 1 and Tier 2 codes that were not priced by CMS. They will continue to go through the local contractors. In some cases, the local contractors are using the MAA codes. In other cases, they are requesting that those tests be submitted under unlisted codes. So again, there will be quite a bit of variability there. And also from a pricing standpoint, the commercial payers, state Medicaid agencies will be going about the process of pricing those tests on their own.
If the 2014 NLA payment rate listed is too low, is it better to use an unlisted code?
Yeah, if you perform a test for which there is an existing CPT code, proper coding indicates that we should use the Category 1 CPT code, and it would be most appropriate to submit under that code and appeal and go through other avenues, such as the open comment process, to um, advocate for a different payment rate. So again, proper coding says use the code when it's available. With that being said, if you are doing a full gene panel, for example, there's a question as to whether gene panels should be submitted under a series of Tier 1 codes or the entire panel should be submitted under an unlisted code. And that is something that can be discussed with your payer. So there are some nuances to that answer that I'd want to make sure labs are comfortable with. And in general, a good rule of thumb is if there is any question about how certain tests should be billed, to always check with your payer to get that clarification.
Great. Another question is there anything I can do to influence low gap fill rates?
Yeah, so, getting back to this question that the NOA amounts are too low, or even in a situation where, let's say, the CMS did not issue an NOA and those codes need to be submitted to local contractors and the local contractors will decide what to do. There are avenues to petition or make comment as to what a more appropriate rate should be. If the code appears on the national NOA, you have about a week's period of time to submit that to CMS. If it's not part of the 2014 NOA, but is something that is priced through your local contractor or other local payer, you certainly have the ability to appeal, have meetings, and provide information to the local payers to try and get them to adjust those rates.
And private payers are the most common payer for my test. How should I handle this?
Yeah, I think there's probably two general rules of thumb. If you are, and many labs and providers in general are working through the process of contracting and setting up fee schedules for next year. Some people may have already completed that process. Many of us are maybe going through that for 2014 contracts as we speak. So I think the first rule of thumb is you should look at historically what the payer has paid you for your test offerings. And that could have been under a code stack, that could have been under the new Tier 1, Tier 2 codes. And you ought to really look at what you've been paid and the appropriateness of that amount. And, with commercial payers certainly making an argument that what was paid in the past should be carried forward, even though the coding has changed, that's a reasonable starting point if you believe that the payment is appropriate. On the other hand, if you feel like the payment has not been appropriate or that the payer may use an NLA amount to negotiate a lower fee, then I think it's really important for individual labs to have a good handle on describing the test, describing the clinical utility of the test, the economic value of the test, and the cost of doing the tests, including directs and indirects, as I said before, and not just criticize an arbitrary amount, but provide justification for why a different amount may be more appropriate. And that's what the lab community needs to do in terms of working with their other payers to try and set appropriate rates.
Great. Any insight on whether small labs can hope to offer gene tests with all the implied overhead of negotiating with the payers and MACs?
Yeah, this idea that this turbulent period of time is going to result in many labs having to bear the cost, the administrative costs, the carrying costs. We know in the early part of this year with the implementation of the new codes, many claims weren't even being processed, and that's a working capital cash flow issue. So it is true that during this period of time, all of our costs are going to be greatly increased in trying to get through this period and educating payers about what those rates might be. And unfortunately, when one talks about direct and indirect costs, these costs probably fall into the indirect realm of overhead, people working in finance or accounting or managed care contracting in order to get this work done, but should be acknowledged there. And then, you'll have to see how the payer deals with those indirect costs. But what I recommend many smaller labs do is work with specialty societies. For example, groups like the ACMG have been very open in terms of trying to work with many of their constituents and labs and provide platforms and avenues so that the group as a whole can present aggregated data to payers as opposed to having labs individually try and fight this battle. So I think as much as you can look to your colleagues and others within industry or the scientific medical community and collaborate to, again, educate payers not only about the value of the test, but how appropriate rates may be established. Some of this will be trying to, again, collaborate as much as possible as opposed to feeling like we all have to take this on individually.
Great. There are some $0 assigned codes, and we're wondering how the impact of government payers such as TRICARE and Medicaid that have fee schedules based on CMS rates.
Yeah, the $0 payment is really, in most cases, it's simply that something was not priced as opposed to saying that it actually has a fee schedule amount of 0. So again, the tests for which a dollar figure was not assigned, those are the ones where with TRICARE, other government payers, state Medicaid as an example, where you're going to have to, through your test menu, educate the payer and work with them to get those tests priced. There's nothing from a statutory standpoint that says just because CMS issued a number that another government payer is bound by that number or must pay at that number. Those are individual decisions.
Okay, it looks like those are all of the questions that we have for today. I thank everybody for joining us. Again, for more information, you can visit www.illumina.com/reimbursement or email us at reimbursement@illumina.com. Thank you.